Okay, so I was mentioning in this slide, this is an overview of our presentation today, so you can have an idea of what we're going to be discussing and the expectations for today's information. We're going to talk about what it means, the LGBTTQ. Sometimes we have a controversy talking about why people try to title the populations in the same construct of acronyms. The purpose for this is important to know that these groups may share some similarities but are all different within themselves. And by no means it means that we are trying to classify the same needs and the same concerns with these populations uniquely. The term for LGBT is commonly used to shorthand the gay, lesbian, bisexual, transgender, transsexual, and questioning individuals. And again, this is the terminology that is appropriately used, culturally competent in every treatment settings and also primary care settings for these populations. To talk about some definitions here, when we say the lesbian, when we talk about the lesbian word, what we mean is that these are individuals who identify attracted sexually and emotionally to the same sex as women. And when we talk about gay, typically is referring to a man who is romantically and emotionally attracted to other men, same sex, and in different cultures we call them homosexuals, especially the Hispanic and Latino. Now it's more common to call gay and is pretty much accepted, but there are some communities that still use the terminology for homosexual instead of gay, depending on their cultural values or beliefs. Also, the terminology for bisexual, the definition refers to someone who is romantically and emotionally attracted to a man or a woman. And being bisexual not necessarily means that someone is involved in multiple relationships at the same time. We're talking about different things. Typically, there is a confusion between bisexuality and polygamous, but it's not quite the same. In this category, we're talking about only bisexual populations. Transgender people, when we talk about the transgender, is basically a variant of the gender identity, mostly than the sexual orientation. We're talking about individuals who are opposite they identify as opposite of the gender at birth. Oh, I'm sorry, I want to clarify, it's a transsexual. When we talk about transgender, it's particularly for gender identity, not sexual orientation. And also I want to mention, if you have any questions, you can type them on the chat, and that way we cover, if you have any questions during the presentation, we can cover your concerns at the same time. So when we talk about questioning or queer in other variants, this is a term, the terminology that covers the umbrella when an individual is identified as either lesbian, gay, bisexual, or transgender, or transsexual. They definitely don't want to be part of any category, and they identify as a queer. That also includes sometimes straight individuals or heterosexual individuals who are participating as an ally to these organizations, to these communities. That is definitely a part of the equality of rights and treatments. The background that we're going to talk about here is that there is a high rate for the stress due to some harassment or discrimination within this population. The higher risk for cancer, mental illness, and other diseases are more likely to be presented. There are higher risk factors for smoking, drinking alcohol, the use of drugs, and also some engaging in risk behaviors, including non-protection sexual engagements, and the HIV and AIDS prevalence also seems to be increasing within these populations. Lack of support or lack of access to care be one of the reasons why. So why mental and behavioral health disparities? When we talk about LGBTQ individuals and our setting for health supports and access to health care, we do not have enough data that supports how many individuals will be there. Most likely, we're going to also not find information related to Hispanic and Latino population. As it is in the general population, we don't have enough data to support what are the high needs, and we don't have sometimes the rates for professional, the professional ratio to individuals and minorities that are in our cities, in our country. So some of that lack of data collection and of the demographics will be a challenge for us to really present and treat all the needs that are related to sexual orientation and gender identity. Also, mental health and social stigma exists against LGBTTQ people, and we all know that that increases the mental distress, causing either depression, substance use, and as I mentioned before, high risk of behaviors. The lack of cultural competency in the behavioral health system also creates very much, this is one of the reasons that creates health disparities, and that we do not have collected enough information to develop programs, training, and resources or technical assistance to our professional staff, including sometimes psychiatrists, psychologists, nurses, practitioners, anyone who is in the health services system. We do not have that availability to really compare what will be our guidelines to support these individuals in treatment. So again, we limit the development of effective assessment tools and health protocols. When we do not have that collection data, we tend to have a disparity, and our general programs do not sometimes are effective to assess the needs for these populations. Sorry, I'm getting this sign. So the increments and diagnosed health confusion is another component of this lack of limited data. We do not have sometimes the collection of what the dual diagnosis of substance abuse along with mental illness in these populations, just because we do not have the collection of gender identity or sexual orientation. Is sometimes very difficult to narrow what exactly are needs for these populations, because it's blended within the general heterosexual populations. And this will affect in a broad aspect of policy and advocacy, legislature, and as we all know, the limited resources and treatment needs. So the use of convenient samples, which creates bias, will definitely affect if the person or the individual who comes for services and seeking for services for mental health or substance abuse will be affected by that bias, including some of the psychiatric and psychological treatment settings. So when we talk about why sexual orientation data should be collected, I wanted to mention my experience working in Arizona. We actually developed an initiative to invite all the stakeholders and supporters of LGBTTQ individuals in treatment. And we created a group, like an advisory group, and designed some guidelines to really provide what we need to provide the services that are targeting these populations by collecting, by adding in our demographics data. So when someone comes and enroll in the system for behavioral health and mental health, they will be collecting gender orientation, gender identity and sexual orientation data. And this is a big, major accomplishment, and it's been already a year almost since this data is being collected, and we have had very minimum collection due to the fact that some of the organizations still refuse to collect data because the assumptions are like sometimes if the person asks, oh, are you part of the LGBTQ communities, and the person already feels biased, let's say the psychologist, the counselor, the health provider will be biased to it, they won't ask that question to the individual, which it will be probably affecting the results and the effectiveness of that treatment, or if the person is engaged or not in the treatment as well. So some of the aspects here that why we need to be collecting this information is important to confirm and explain the results of our recovery process. Also, we need to develop policies and programs that impact the lives of LGBTQ individuals, including the Latino and Hispanics. Again, sometimes the treatment or cultural competency just focuses on the class standards or the language or the English proficiency, but not necessarily when we serve Latinos and Hispanic, we're talking about language and disparities on cultural values. We're talking about the importance of identifying minority within the minority, which is LGBTQ in this case. So where to start? How can we start addressing these issues in our organizations? So you have to also recognize how your organizations, what kind of role they play in community. We need to recognize that some individuals may have these thoughts of fear government and health institutions. They feel that it is not what they want to do in their lives to really come to look for help. Instead of that, sometimes they try to comfort their needs into substance use, into high-risk behavioral factors. So what we're talking about is the refugees and immigrant Latino and Hispanic communities, staff and resources. This is based collected in the assessment, and when you better understand the penetration rates for LGBTQ populations in your organization, you can enhance those programs, or you can train your staff more appropriately to serve these populations instead of experiencing that these individuals, when they have treatment, sometimes they don't finish the treatment, their relapse is higher, etc. So we need to understand what are the high needs and how we are able to support these individuals and how our staff is trained to support these individuals. Another way to understand what will be the role in your community and what is the makeup of your community is developing some surveys and focus groups. To meet with the leaders in the community, similar to what we did over here, we started reaching out to those individuals who were supporting these populations first. And then we were talking about what you do, how do you see the effectiveness, how you can share your pros and cons of the treatments, etc. So talking about it in the community with your counterparts is also going to be increasing the opportunity for healthy communities, not only for these populations, but in the general population as well. Request feedback and input on how to improve changed outcomes for services. Typically, there is a satisfaction survey to clients. You can do that, and like every month, by annually, and then assess how these individuals who come for services with your organization, they feel about the treatment, how they feel respected, if they were feeling themselves, they don't have to pretend to be someone else to be on the treatment. Sometimes with the Hispanic and Latino particularly, we tend to have that the double standards values where people say, if you're gay, if you're lesbian, etc., you will not be welcome in the society because of the values, and it creates a lot of controversy on that for the individual when he seeks treatment as well. If they understand that in the society where they're coming from, when they look for access to health, they will definitely feel that the professionals will also discriminate against them, and that is one of the reasons they don't open up to them, and the treatment will be not appropriately culturally sometimes in these cases. Also, you need to assess the language proficiency in both communities and organizations. We need to match our populations and the clients that come to our services and try to serve and have as much staff available to provide those within their own language. So when we talk about mental health and social stigma, we have high rates of high-risky behaviors, including suicide, tobacco use, drug and alcohol. Also bias of disclosure process. Here is very, very important to understand that to provide support to any individual who come and identify as an LGBTQ, we need to be very careful in which stage of the disclosure process they are within. For example, the disclosure process can call us as a coming out process or out of the closet, etc. So when we have this bias and the person is already struggling whom they're going to disclose or not their sexual orientation or gender identity, that is extremely crucial for the treatment, whether or not it's going to be effective or recovery is going to be a fully processed, and at the same time it's going to create less stress for the individual during all this process. We also have a stigma of the dual stigma, which is being part of the lesbian, gay, bisexual, transgender, transsexual questioning individuals, or mental illness at the same time. Later we're going to talk about a little bit of the history on these assessments and the homophobia and heterosexism. Faith, religion, spiritual issues, victimization, hate crimes, isolation, family rejection, and homelessness are also part of the social stigma within these populations. And some of the research and studies mention that this is, within these populations, is higher rates, and we need to start collecting our data in our own communities to find out how big of a problem is homelessness, how big of a problem is hate crimes in our communities, and then address our data that we collected as well. So in the American Psychological Association, they removed the DSM-IV diagnosis that addresses that homosexuality per se implies no impairment in judgment, stability, reliability, or general social and vocational abilities. Further, the American Psychological Association urged all mental health professionals to take the lead in removing the stigma of mental illness that has long been associated with homosexual orientations. In historical perspectives, we see that homosexuality and bisexuality were addressed in the 40s and the 50s, the same-sex sexual attraction and behaviors as a mental disorder. In 1957, there was also a study that finds gays and lesbians as normal. What happened in this study is that Dr. Evan Hooker, she did a research and found that analyzed different a heterosexual adult individual with their brain and a homosexual individual's brain, and then she found out that, oh, they are the same, so they all have the same capabilities, so there is no mental, both considered normal in quotes. And that was a progress by then, but then in 1973 is when the APA removed the homosexuality as psychopathology from the DSM. So once we have all this history that provokes a lot of stigma around these individuals who basically declare that they are either with a mental illness or not normal to the general population, we still have, despite all that, we have progress, but we still have some bias. And those individuals who create those biases in the society are called typically the homophobia or the heterosexism. The homophobia refers to an irrational fear of gay and lesbian people or fear of the same-sex relationships. And in its most extreme form, homophobia is a series of violence and against the LGBT people, and it creates sometimes, we see a lot of crime related, a lot of bullying in the young populations. There is a lot of cases of suicide due to this anti-gay or anti-lesbian movements, and unfortunately we see young people that are not quite pure. They don't accept themselves due to this society pressure, and they just cannot live one more day. And that is exactly what we think about when we are responsible for providing the treatment and recovery for these individuals who are in high need. Heterosexism is an assumption of heterosexuality and the heterosexual perspective as the predominant of meaningful viewpoint. We're talking about the duality gender of women and men, and that's it, the other option in the society, and that's all we need to work on when we have a variety of individuals who do not fit into gender identity. Biphobia is fear of hatred for bisexuality. Unfortunately, the terminology of the people who identify as a bisexual is yet also, on top of being discriminated by the general population, sometimes also a discrimination within the LGBT community. But it's part of the umbrella, and the reason why this fear or hatred is there, any phobia, because of lack of knowledge and lack of understanding of the whole meaning of LGBTQ. Transphobia is fear of the hatred for transgender persons. And then again, we have a lot of lack of information related to the transgender populations, and there is a lot of individuals who have a lot of issues traveling or legal issues, especially when they change their identity to opposite sex, and previously they have, let's say, passports or any documentation as a woman, and then they change the gender and they change legally their name, but when they travel, when they do any kind of legal processes, they have to demonstrate that they were this person before, and they have to deal with all these transitions. So sometimes a lot of individuals do not understand that pain and that fear and that discrimination that these individuals go through. But on top of that is rejected by the society. So we need to take in consideration where we are standing, where we are located in our own areas, and try to transform that and reduce the bias and stigma, eliminate the stigma related to this. So the most commonly identified mental health issues are anxiety, depression, suicidal ideation attempts, post-traumatic stress disorder, substance abuse, and dual diagnosis. We're not going to go in details on this as we all know what are the disorders, but what I want to point out is the dual diagnosis, because we have sometimes a substance abuse, mental illness presented in these clients, but then on top of that, sometimes they have another chronic disease that they include the integrated health care and primary care as well. So imagine this individual coming to our doors, and they already have to go through the whole enrollment process and all these questionnaires and information that about them, why they having these issues, and then they have to also deal with the medical staff, which sometimes do not have the same understanding of the cultural values of these individuals, and the treatment cannot be as effective. Let's say we have a person who is taking psychotropics and also on medications for diabetes or heart hypertension, and when we do not work together and we have embracing this this identity of the person as it is, sometimes the problem is not necessarily that it is the sexual orientation and gender identity. Sometimes the person is already in acceptance, and that is not the issue, but for the medical perspective would be, and sometimes we create that that biases in between the health system that we have to move forward with our guidelines again. We're gonna also talk about the rates for suicide. Higher rates for suicide are demonstrated in youth, but are that they were more likely to hurt themselves in purpose for 44% versus the 17% of the counterparts. They also have considered suicide. They reported 34% versus the 11% of the counterparts, and they may have suicide attempts in the past year for 21% versus We don't have that listed here, but it will be around 10%. So while we are looking at substance abuse and comparative rates, we see in research where women who are lesbian or bisexual show a higher risk pattern of alcohol use throughout their lifespan than heterosexual counterparts. In Hispanic populations, we tend to use alcohol as a the acceptance of alcohol in our society is very common. But sometimes these individuals who live double life or who do not be accepted in the community, that tend to abuse more this social accepted alcohol intake, and then it becomes an issue, it becomes a problem. So in the Hispanic and Latino LGBTTQ, we have also the consequences of multiple stressors such as racial, ethnic discrimination within sexual minority communities, and anti-gay values. Again, we have a society that the pressure and acceptance is not yet fully. Is a lot of disparity in that connections as well. And the Hispanic sexual minority women may experience additional stressors if they are perceived to violate conventional feminine norms in the Hispanic community. So on top of everything, on top of the health needs and the lack of healthcare appropriate services for LGBTQ, they will have to deal with their own system or supports in the communities to prove themselves. We also have another study that men spoke about their need to immigrate in order to live openly gay lives, whereas other mentioned living double lives in order to prevent homophobic experiences. All the anti-gay movements create these stresses in these individuals, and it's going to for high risk is going to increase. Assimilation, acculturation, and religion are main factors for these individuals and how we can support them. It remains very difficult, but not impossible, to develop sensitive health services in response to those Hispanic needs for these populations. We understand that there is a stress when someone comes from, like, immigration laws are not supporting same-sex marriage, for example. That can be a problem. That can be a lack of support for these individuals, and not to mention the religion. There's some discrimination against us and against this community, the faith-based communities, but we need to make sure that we know the resources and where to refer those individuals when they come to our services, and we need to make sure that they are in a level in their acculturation, assimilation, and the way they feel in this country, and how we can support them to the resources in the community, including the faith-based organizations. So when we talk about competency, the performing minimum quality of services that provide those high needs for these populations and experiences the practice of the professional with statutes that are going to support what are the best practices for these for LGBTQ individuals. We have to fill up the gaps and try to develop some training and technical assistance, as well as referral to services. If it's not in our services, we can recommend someone to help us. And there are some allies, community organizations that they can actually be addressing the healthcare concerns and the needs for these populations. One of the most challenging aspects, again, is their spiritual needs with their child religions, upbringing, and their belief systems that was part of their family system. Let's think about those minorities who live in this country that do not have those supports that they had before. Now they have to develop some family of choice, some environments for themselves to support those needs and to be part and belong to a community that is going to be continue for their values and their beliefs and practices. So the counseling, that when we talk about challenges and finding options for clients, We need to understand that we have to open conversations with our clients, and we need to talk about how they feel in the process and how they feel if we help connecting them with peers or any other groups that we have in our community to support those same challenges. With the treatment, in the treatment area, I'm going to be focusing mostly on the sensitive and mostly on the affirming treatment at this point. What we're talking about affirming treatment is to be, the whole staff is open to identify as an LGBTQ to start with. The organization is in support of equality and reflects the environments that are safe to be out, and also is client-centered, promotes and honors self-identification, and recognizes all the relationships as valid. And that includes all the family and family support system and friend support system they have that may be included in the treatment as well. So everyone is welcome to our treatment and use the correct terminology to address these needs. To promote prevention, we need to understand that the disclosing their sexual identity in schools, community centers, workplace, and public settings is crucial to address the preventive strategies and methodology that is going to help these families and engage these individuals to partner with us in prevention is very crucial. So we need to develop the needs assessment and try to identify again what is our makeup in the community and try to target what are the high-risk factors in our communities. Some risk and protective factors for LGBTQ youth, including the social support and social bond with peers, community support, and positive adult role models. What to do is to create a safety for LGBT individuals, become familiar with their culture, values, diversity, and resources. We need to acknowledge clients' significant others and encourage their participation in treatment, be guided by LGBTQ individuals as well. We need to take that feedback and get the training to increase knowledge and understanding the LGBTQ individuals' needs. Do not label, do not pressure individuals to come out. That is on their own pace and that is their own choice. Do not ignore significant others or important family of origin or family of choice members. And most importantly is that we need to be very compassionate when we do serve these populations and very assertive in how we ask the questions, and we need to educate ourselves. So here are some few recommendations to develop appropriate language, culturally appropriate language, understanding what is sexual orientation and gender identity. The coming out process is very important for any person who is dealing with substance abuse as well, and see where they are in the coming out process in life. And creating a welcoming, safe, and supporting environment for LGBT persons. We can actually put in our lobbies, in our luncheon, etc. We can put signages that are welcoming, safe environments in our organization, and that way we can actually be more inclusive with the clients that we have waiting in our areas. This is a social determinant in health disparities. We need to consider all these variants, all these indicators to find out where the person is exactly, where they are in the society, how they value. We need to also understand that on top of this, religion, spirituality, health status, sexual orientation, gender, ability, disability, etc., where they live in urban and rural, all these factors will determine whether or not the health disparities will be part of our organization and the way we serve these communities. We need to make sure that race and ethnicity are part of the process of treatment and recovery, and by that we are going to create safer places for our communities and the way we serve our clients. So resources that I listed here, I want to mention especially NAMI. NAMI has a very nice videos of LGBTQ peers who actually talk about their own experience, and it's very interesting. You can get more information on that. So, any questions?
Thank you, Cielo. We actually have a couple of questions here. Do you think that trying to speak out about sexual orientation in a session will alienate people if we don't focus on their behavior rather than on their sexual orientation?
Basically, this is again the importance of it's not of our own concern, it's their client concerns and choice. We are not going to tell them, oh, you have to come out, you have to do this, or you have here to see me for treatment because you want to be heterosexual or something like that. It's not about us, it's about them. So when we collect this data, and as I mentioned in Arizona, we're collecting that already in the behavioral health system, gender identity and sexual orientation is a choice. And anyone who identifies and who is already out in the community and is an advocate and is an activist will come and will definitely try to be part of this. It's about them, and I think the best question to ask when we have these individuals for services, we need to ask them, okay, so how do you identify yourself? If that comes in the conversation, if you're not already collecting this data and the practice officially, you have to ask if this is if that influence the reason why they're depressed, if that influence the reason why they are abusing drugs, etc. So we need to find out if the acceptance of being an LGBTQ individual is the problem, is the issue, or not. So it's not up to us, but we as professionals, we need to find out if that will be an issue and then address that.
We got another question here. Are there any special issues for subgroups in regards to sexual orientation and mental health? For example, place of origin, lesbian Chicanas, or for example, transgender male from, let's say, male to female, or, those type of things.
If there is a what? I'm sorry, I couldn't hear
if there's any special issues or considerations that you might notice for this subgroups.
First than anything, in any of these with these individuals, further than anything is to know where they're at again in the coming out process and where they are as their personal identification. There's some individuals that I have counseled that they were for 30 years struggling with identifying themselves. So once they already know and they accept themselves and they really deal with that, it's not up to the society to understand them. They already understand themselves. So they will be, that part, I think what we need to be, again, is very compassionate, educate yourself, and never try to solve the problem coming from the perspective that they need to be heterosexual or they need to fit into this or that category. You need to understand as a professional, you need to know what is the health issue they came to see you, and then address those as a secondary if that is an issue. There are some supports, peer support groups that are personal family support for like a GLSEN, like a Wingspan. There are a lot of organizations that have this literacy, and they have advocacy groups. They have a lot of resources for families and individuals. So I think it's our responsibility to know more and be more aware of those community groups in order for us to make appropriate referrals. But it's never to assume or to put more stigma onto, oh, they're coming from this LGBTQ, either or, so I'm going to be trying to fix them, in quotes.
Thank you, Cielo, for addressing those questions.
Thank you, sir.
Thank you.
I think what you say is very important. It's important to be sensitive to anyone's issues. And regarding your recommendation, I think it's a really good recommendation that you include, for example, in your assessment forms, that the person can self-identify. and also let them know that they have the option of not responding if that's not something they want to do at that point. Like you mentioned, you need to be aware of where in the process that person is. So I think that's a really good recommendation. I want to let our participants know that we have a few more questions, but what we're going to do is that we're going to give our presenter those questions, and then we're going to post the answers on our website. Okay? So we'll be doing that approximately a week from today. Thank you again, Cielo. And for our participants, remember that a recording of today's webinar and PowerPoint slides will be posted and available at our website at www.attcnetwork.com/Hispanic Latino. Also, your feedback is very important to us. We are concluding the webinar, but we are going to take a moment so that you can answer some questions. We have a brief survey about your experience. So if you can give us feedback about that, we really appreciate it. Thank you so much, everybody, for attending, and have a great day.
Thank you. Have a great day.
Thank you all.
Thank you.